Welcome to this talk on an exercise-based approach to voice therapy. I'm Dr. Judy Wingate. I'm the professor and chair of the Department of Communication Sciences and Disorders here at Jacksonville University in Jacksonville, Florida. Let me go ahead and give you the objectives for the course. By the time we're done with this course, I hope that you will be able to describe rationales for using exercise-based approaches in voice therapy, that you will understand how to link respiratory strength training with voice therapy, that you will be able to demonstrate how to perform semi-occluded vocal tract exercises, and that you will be able to explain the benefits of singing exercise for individuals with Parkinson's disease. So first, let's just talk a bit about the benefits of exercise. I know that you've completed a course on respiratory muscle strength training, where you've probably already discussed these. In terms of voice therapy, we know that exercise has very positive benefits for voice production, that most people who exercise notice reduced fatigue, improved strength, improved maximum phonation time, and so forth. I like exercise-based approaches because it gives our patients something very active to work on. Many years ago, when I first started in the field, in voice therapy in particular, we were pretty much left to deal with things that the patient could either feel or hear that were different in their voice. And for many people, that was very, very difficult to do. They just weren't able to hear a difference or to feel a difference. And it made our jobs much tougher. So exercise is something very concrete that we're not reliant on perception for. We can also provide charts for our patients to be able to chart their progress so their results are very visible. And that's a huge motivator for many people. So quick results and very motivating. Typically with exercise-based approaches, our goals for voice exercise are as follows: to improve vocal function or quality, to help our patients or clients coordinate the subsystems for voice. So coordinating respiratory system, the laryngeal system, and the resonance system. And then particularly strengthening laryngeal, specifically intrinsic laryngeal muscle with abdominal muscle, particularly exhalation, so that expiratory muscle strength training. This is especially important for our clients over the age of 65, as the rate of sarcopenia, so the muscle atrophy and the weakness, begins to accelerate after 65. And we know that exercise can mediate some of that deterioration that comes with normal aging. I'm sure that this was covered in your course on respiratory muscle strength training, but I wanted to just touch back on it briefly. So we know that in order for a muscle to change, the demand on a muscle must be increased. This can be accomplished by increasing the frequency of exercise, the duration of exercise, the intensity, and the type of exercise. From that exercise physiology literature, that periods of rest need to be included in our exercise in order for complete muscle adaptation to occur. We know that exercise must be specific to the activity. So if we want people to improve their voicing, we need to have them exercising their voice. We also know that exercise must be tailored to an individual's needs. We have to start where that individual is and take that individual to where they would like to be within their physiologic capability. We also know that exercise results or exercise changes are reversible, and that detraining can occur very, very rapidly, as early as 12 days after the end of training. with complete detraining happening within a period of about 4 to 8 weeks. And a lot of this comes from work done by Scott Powers and Howley, who published it's worth a read to understand what our colleagues do with muscle training. It has a lot of applications to what we do as clinicians in the speech world. So for frequency of exercise, we know that it should be at minimum 3 days a week. If we're going to do low intensity exercise, 20 minutes or longer. If we're going to ramp up the intensity of the exercise, shorter, certainly doable for most of our patients. We may have to start them with a lower intensity, particularly if they're recovering from or trying to minimize a lesion. We may want to start lower and increase as we go. The greatest change will probably occur within that first 8 weeks, which dovetails nicely with our typical average number of voice therapy sessions, which is typically 6 to 8 weeks. Our maintenance stage needs to continue, of course, beyond the time that our patients are in treatment. They can continue to do the exercises at a lower intensity than initially, so perhaps fewer days a week with fewer repetitions. And that's typically doable. Most clients are willing to comply with that. Of course, we know at some point they're likely to stop doing their training because life gets in the way. But they will have the tools, and this is worth a reminder to them, to go back and start practicing again if they notice that their voice is beginning to deteriorate or weaken. So how do we integrate respiratory muscle strength training with voice therapy? There was a study done a few years back with Nelson Roy, Barb Weinrich, Joe Stemple, and Chris Sapienza, among others, with teachers that tried to compare voice amplification to vocal exercise to expiratory muscle strength training to see which one made the biggest difference for teachers. As a doctoral student at the time, I read that study and it sort of had an aha moment. One of the findings was that expiratory muscle strength training increased inspiratory and expiratory muscle strength, but it didn't really change teachers' perception of their voice in terms of improvement. And I had that aha moment of, well, gosh, you didn't teach them how to apply that strengthened pump that they got from EMST to speech and voice tasks. In fact, I used that in my own dissertation work, that we had half of our cohort professional voice users do expiratory muscle strength training first, with half of the group doing traditional voice therapy. And then we did a crossover design where then that group that did voice therapy did expiratory muscle strength training. Almost every one of the participants in the study said, oh, that's what you meant by taking a breath and controlling with abdominal muscle. After they had done the EMST, they were much more able to relate to what that muscle should be doing. So ever since, I've tried to combine the two things together when possible. Vocal exercises are a great transitional activity for this because we can focus on applying that increased strength of the pump to just voice production at its purest. And lastly, being able to incorporate that improved control for phonation into everyday use. So you're already familiar, I'm sure, at least in name, with some of the exercise-based programs that already exist, and there are trainings available for these, both online and face-to-face when that's able to happen again. Silverman voice therapy is one of the most researched and widely available. That is intended for people with Parkinson's disease. but it's also been applied to other groups. The Forte program is relatively new. It was developed by Aaron Ziegler and Edie Hapner, specifically for individuals with presbyophonia or presbylaryngitis, that weakened voice from muscle atrophy and aging. It has similar features to the Lee Silverman program, as do all of these share similar features. The Lesak Madsen resonant voice therapy program, it was taught to most of us by Dr. Kitty Bertolini, and it focuses on client perception of resonance in the mask of the face, combined with good respiratory support for speaking and effortless, efficient vocal production. Vocal function exercises were introduced to most of us by Dr. Joe Stemple, who's now retired. And it was a great exercise program. And I'm going to go over the steps in that program with you in case you aren't familiar, because it segues nicely into the next set of exercises that I'd like to talk to you about. So before we get into that, let's go back and look at how do we know what kind of changes exercise might produce, and do they produce a change in the muscles of the larynx? And can those be helpful with age-related changes? So you can see at the bottom of the slide, there's quite a few studies, and these are just a handful of the studies that have looked at exercise-based approaches and the evidence for using those. So most have found that our speakers get an increase in maximum phonation times post-exercise programs. They typically report improvement in perceptual ratings or in listener ratings of them, of breathiness and strain. If acoustic measures have been done, we hear a change in noise to harmony for roughness in the voice. Our clients or patients experience a decrease in vocal fatigue post-exercise programs, as well as a decrease in phonatory effort. And then some of our animal studies, which in cats, sometimes dogs, show cellular changes in glycogen storage. That is a fuel source for muscle energy, as well as at the neuromuscular junction for improved neural transmission of signal post-exercise. So you might be wondering, how do we know that muscle changes? Well, a lot of these studies have been done in animal models. When we take a biopsy, as exercise physiologists do, they would do a punch biopsy of a muscle pre and post exercise, and then compare the change in that muscle tissue post exercise. If we do that in the larynx of a human, we've lost critical tissue and we would have damaged the voice. So we're really dependent on these animal models to be able to do that same comparison. There are a lot of similarities between an animal larynx and a human larynx. It's not perfect, but it does seem to do better. It's very difficult to do those kind of studies on a cadaver larynx because of tissue deterioration. So right now, this is the best evidence that we have. And then, of course, we can do behavioral studies using exercise, but we're left with perceptual and other quantitative measures that can be made in a laboratory. So the vocal function exercises, Dr. Stemple would tell you that they're designed to balance the three subsystems of voice: the respiratory system, which we've learned how to strengthen, the laryngeal system, and the resonance system. If you think back to your anatomy days, you know that the resonance system is above the level of the vocal folds. So the vocal folds themselves are producing a buzz, and the resonance system produces the other changes that we hear. It amplifies and filters that buzz to turn it into the voice that we hear and the speech that we hear. So Dr. Stempel's system is very simple. Here are the 4 steps of the exercise. The first is to produce a nasal E sound on an F. For women, that's typically done above middle C. For men, in the octave below. You have the client hold the sound out for as long as possible and as softly as possible. Engaging respiratory muscle, that's important. You don't want strain in the neck, and you want a clear sound, not sung. It's harder than it sounds to do. I'm actually using a pitch pipe to give a pitch cue for this. You can find these online for under $10. There are also programs online that will generate a pitch for you. You can use a keyboard. There's lots of different options. So here's that nasal tone. Now I could hold that out a lot longer. I'm not going to in the interest of time. You have the patient do that twice. You can record the time on a stopwatch and then have them record that on paper, or you can record it on paper for them. And that's where we can begin to compare improvement. Sometimes with really dysphonic patients, they may only be able to hold that sound out for a second or two, and that's okay. As long as they can produce a sound, we can begin to use these exercises. The next step is to do an upward pitch glide. Dr. Stemple uses the sound of knoll. I prefer to use no because it's just easier for most patients. Again, the idea is to do this softly. The goal is to do it without pitch breaks. So you glide upward on that sound twice. Downward glide on the same syllable. You also want to encourage the client to produce the entire range that they're capable of doing. And they may give you a very limited range in the beginning, but you need to encourage them to do this as maximally as possible. The final, you don't record the time on those, by the way. I find my students often trying to do that, and that was not intended for the glides to be timed. Then you're going to do what he calls the power exercise, using that same syllable on 5 distinct musical pitches. Again, softly, as long as possible, typically starting on middle C or the C below for men, moving up to the G. So it may sound something like this. Again, I could go longer. I'm not going to do that. And then you would move up. So it's really on a do, re, mi, fa, so scale. So, no, 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 but holding those out as long as possible. And then you would have your client do those twice a day, 5 days a week at home. So you're building in 2 rest days. They can choose which days they pick, and you time those musical pitches. I want to make a point here. Dr. Stemple, when he teaches these, spends a great deal of time on technique, making sure that the client is engaging good respiratory support, not straining muscle, really engaging the resonance system, which is certainly important to do. I have encountered patients, as I'm sure you will if you haven't already, that cannot match pitch. In my humble clinical opinion, that's not what these exercises are designed to teach. You could spend weeks trying to teach someone to match pitch. And that's not what's important here. The important thing is getting them to produce pitches and coordinating systems together. So you can adapt these exercises. You may have a patient who's not able to produce 5 distinct pitches. So you go with 2 or 3 and build on those, and you'll still see results. I confess that I learned these from a book initially and used them with quite a few clients before learning to do them correctly, and still saw benefit. So I can attest to the fact that they do work even if you don't do them perfectly. I forgot to mention that I have over 35 years of clinical experience, at least 15 of that dedicated primarily to working with patients with voice issues. So I can tell you that these are good exercises and that really do work well. I've become more acquainted in the last 10 years or so with semi-occluded vocal tract exercises, and these go by different names. In fact, what we just covered in the vocal function exercises are semi-occluded vocal tract exercises, but we can make it even easier for our clients. These have been used in Europe for a long time. You may see them referred to in some texts or articles as flow-resistant tube therapy. They can be done, and Stimple incorporates lip trills or tongue trills into the vocal function exercises. So with a lip trill, a tongue trill, which I'm not good at demonstrating, but it would sound like this. I just have a hard time keeping that going, but for some clients that may be easier. What I think is the easiest is the straw, and you see some other options there, humming, placing a hand over the mouth. I like the idea of a kazoo. It's the same principle. The tube is a little fatter, but you have to hum into a kazoo to make sound, which can be great for children. And I didn't mention that we can use these same exercises with children just as we can with adults. So if you're a pediatric therapist, have at it. They love it. And parents can do them with it. So you could use a kazoo for that, but a straw is simple. And you can find different options for straws or tubes. If you go to the hardware store for pennies, you can buy different sizes of PVC tubing or aquarium type tubing, which can have a very large bore, or you can have a large bore milkshake straw, or you can go down to a tiny coffee stirrer and change the resistance for these exercises, making the exercise harder. I typically just start with either a milkshake straw or a regular size drinking straw. You can have the patient just hold this between their lips very gently and make an ooh sound into the straw. You can do pitch glides, you can do the Stimple vocal function exercises, or you can devise your own exercises, but simply phonate into the straw like this. Ooh. Ooh. For kids, sometimes they do a siren sound. Ooh. So you can be creative, and we'll get into the theory behind why this works in a second. This is a great exercise because it can be done very quietly. Some of our clients are uncomfortable exercising their voice, particularly when other people can hear it. Even if they're with their family members, they may be reluctant to take a chance and make sound. The advantage of the straw is it can be done very quietly. So if you have someone who lives in an apartment, they can do this without disturbing their neighbors. It works in a dorm room. It works in an assisted living facility or in a skilled nursing facility, etc. It can also be done in a busy clinic without disturbing the audiologist maybe who's next door, as I used to have issues with. So it's very easy to teach and very easy to learn. It doesn't require expensive equipment. You can use this for any kind of voice strengthening. So a patient with a paresis, a vocal fold paralysis, a muscle tension dysphonia, any kind of dysphonia, vocal fatigue, presbylaryngitis, any of that, it's useful. So the goal is to produce normal vocal intensity with less mechanical trauma to the tissues. How does it work? Well, Ingo Tietze, who is an incredible, brilliant engineer, but also voice scientist and singer, has done some theoretical work on this as early as 1996, and that work has continued with others. The partial occlusion of the vocal tract essentially creates a standing wave in the vocal tract. And I know this is going back to acoustics or speech science, which many of you may not recall fondly. But that standing wave can actually help lead to enhanced glottal vibration. So it is heightening the interaction of the vocal tract with the vocal tract filter or a resonance system. It is promoting an impedance match between the vocal folds and the epilarynx, which is the supraglottis. It is raising the supraglottal and intraglottal pressures, which if you recall is part of how we keep vocal fold vibration going. So it's giving nice feedback to the patient. It's actually feeding acoustic energy back to the vocal folds, which in turn helps them produce voice in a more efficient manner. And it may even contribute to a singer or speaker's formant, which means more efficient phonation. So it's a win-win. It's easy, it's fun, it's not stressful, and it doesn't require fancy equipment and can easily be used as home practice and combined with any of these other exercise-based programs. So I our clients from doing just vocal exercises to using that improved voice and speech. And this is just straight voice therapy or speech therapy, using that hierarchy of speech tasks. So beginning by incorporating very short phrases early in the exercise program, moving to longer phrases, and then using short conversational exchanges, moving on to longer exchanges and reading, help make sure that our clients are able to easily incorporate all the things they have learned in that more efficient conversational speech. I just wanted to touch briefly on singing exercises for individuals with Parkinson's disease. There are quite a few singing groups now across the country, some in Iowa, some in Texas. We have one here in Jacksonville for a while. They've really caught on for a lot of different reasons, but I wanted to mention some benefits that we found from the exercise specifically. So singing uses the same systems that are involved in speech production, including vocal and respiratory exercise, with an emphasis on increased effort and loudness. You may think, gosh, that sounds a lot like Lee Silverman therapy. Yes, those same ideas, but utilizing them in a group setting. An additional benefit is that the group interaction gives a lot of social support for clients, and it may be a more motivating. So within the group sessions, doing some lip trills and buzzes, which you recognize are semi-occluded vocal tract exercises. But lip trills are particularly good for making sure that you've got a steady airstream coming up through the vocal tract. It's really hard to do a good lip trill without having good breath flow. Then doing glissandos, trying to expand that pitch, which may become more limited, particularly as Parkinson's advances. So starting with small intervals, moving to larger leaps, doing a mezza di voce exercise, which literally is starting out holding a note very softly, increasing the loudness and then decreasing the loudness again all on one breath. I don't do it well, which is not the point. I'll try to demonstrate for you. So starting off with a ooh, and doing that in a very controlled manner. That gets better with practice. Doing some articulation drills, really emphasizing a lot of articulatory or over-articulation movements with consonant vowel combinations on 5-note patterns. That sounds a lot like singing exercises that singers do. Mi, me, ma, mo, mu, li, le, la, lo, lu. Change singing intervals and varying the scat singing, if you're familiar with that. And then having the group sing familiar songs for about a 15 15 to 20-minute period. And those could be songs like God Bless America, Country Road, Take Me Home Country Roads, Show Me the Way to Go Home, Home on the Range, anything that the group likes and is familiar with. We even had requests for some Beatles songs in the group singing time. I've been involved in at least 2 of these studies, which I've referenced here. And we have another that we're just getting ready to submit. And others certainly have done some work in this area. Some of the findings from these studies have shown improvement in functional residual capacity. So an actual improvement in the spirometry measure of how much air we can hold in our lungs, improved quality of life scores, improved prosody, speaking pitch, rate, and loudness for speech, even though we weren't working on speech actively as part of the singing exercises, of course. One of the studies by Stegmuller found improved laryngeal elevation during swallowing as measured by EMG. We didn't have the grant funding in that study to do video fluoro studies, but EMG was what we could manage financially, and we did see improvement in that. Increased respiratory pressures, MIPS and MEPS, which you know about from laryngeal training or expiratory muscle strength training, without specifically doing expiratory muscle strength training, which is interesting. And in the last study that we're getting ready to submit an article on, improved peak flow, which is one of the components of cough, which is suggestive of perhaps singing may help our Parkinson's patients with airway clearance. And we know that aspiration is one of the things that can lead to death in our patients with this dreaded disease. So there could be benefits that we haven't even thought about from a singing exercise program. Again, fairly inexpensive, can be done in an hour a week in a communal setting, and can be really a community service type of event for our residents with Parkinson's disease. So just to conclude, I hope you'll see that exercise-based approaches to treatment are beneficial to our clients. They're very easy to apply, and they're readily adaptable to home practice. I think too, they can make therapy more engaging for us and something that is more approachable for many of our clients. If you have questions, I'm happy to take them. I know it's always more fun to have a conversation than to listen to something online. So if you have questions, I'd encourage you to email me. This is my work email address. It's my name, first initial, last name with a 2 replacing the E at ju.edu. Thank you for your time and attention. I hope you enjoyed the presentation.